Hello, everybody. I'd like to welcome you to the courses of Pathology 1 in this semester. We'll have our contact today via WebEx, the platform, but I hope soon I'll have the pleasure to communicate with you in person. I'm Andreas Lazaris, professor at the First Department of Pathology, and for this semester, I'm going to be your supervisor. So anything you can, you want to ask or you want to talk with me, you can mail me, text me, or we should be in contact. So before our first lesson, I'd like to show you the some sort of the. Have you seen the e-class? Let's have a look and see your portfolio. Here we are. So you have to have a look at the description because you'll see all the teaching material for this semester, all the chapters from the Robbins textbook you are going to study, and we're going to study together. And you'll have a look at some information on our course. And don't forget to check the announcements, because this is the way you are going to get informed about our lessons and all the educational activities. It is good to get in the site and have a look at the announcements, because of course, if you are registered to the lesson, you'll have the announcements on your mobile phone. But since in the mobile phone there are too many messages, too many information, please have a look at the announcements so that you are sure that you know what we are doing. In the documents, you can see all the chapters of the textbook, and we'll upload all the educational material which you have primarily to study, because this will be in the responsibility of each educator, meaning that, of course, there will be a textbook which you should all study, but above all, you must study the slides that are uploaded in the documents, because this is the material on which your exams will be based. And you'll have a look at all the active modules of the lesson. And as I told you, we can communicate via email messages or in person. So till we start our lesson, since you've already studied histology, I'd like to have a look. I'd like to have a look with you at some basic tissues, because our lesson is histopathology. So we have to be familiar with the normal structure of tissues, so that we can understand what's different in pathology. For example, let's have this slide here. We'll try to communicate so that we'll have an interactive parameter in our lessons. Would somebody like to tell me this tissue? Can you recognize this tissue here? If I tell you that it's skin, it's from the skin, can you tell me what are these cells? You can say anything you like. Of course, the lessons are recorded, because I'll upload them on my YouTube channel, AC Lazaris Histopathology. This does not mean that you should be embarrassed or in any way reluctant to participate in the lesson, because you are students, so you are not supposed to know everything. I'm not examining now. I'm just trying to communicate with you, because I believe in interaction and communication in education, as we'll see further on. So, would you know what this tissue? Do you know what the tissues are generally? The kind of tissues. Do you remember from histology? Would somebody like to talk to me and listen to your voice? What kind of tissues?
Is it
Yes,
stratified
please.
squamous epithelium with
Yes,
keratinization?
excellent, excellent. This is the squamous epithelium because one basic kind of tissue is the epithelial tissue, and many epithelial tissues are covering epithelia, one of which is the skin. And as you uh, told me very well, this is keratinization because the squamous epithelium of the epidermis keratinizes. Why? Because there are some stressful stimuli on our skin, so this epithelium keratinizes. And you see the keratin layer, right? Now, let's have a look. Since this is a covering epithelium, and renews itself, there must be some cells which are the proliferation zone. Do you remember where these cells are located in this tissue, in the epithelium? Does somebody remember where these cells that constantly proliferate and they become more mature as they go to keratinize? What do you think? Which cells are they?
They are the beginning of the purple layer.
Louder, please.
Are they at beginning of the purple layer, the more purple layer, the basal layer?
The basal layer, yes, here they are. This is the proliferation zone, and as you can see, these cells appear a bit darker than the ones that are in the upper layers. What does this mean? This means that these cells are more primitive cells. That's why they proliferate. And we have a staining feature which reinforces this nature. For example, which stains do we use in histology and histopathology? Which are the routine stains? It's hematoxylin and eosin. What does hematoxylin look? What color is hematoxylin in our tissue slides? What color is it? Hematoxylin. And which part of the cell does it stain? What do you think? There is no problem if you don't know. That's why I'm here, right? That's why I'm here, to talk to you and communicate. Above all, education is interaction, communication. So, do you know what stain hematoxylin, what color is hematoxylin stain?
Purple.
Good. And it stains which part of the cells?
The nucleus.
That's why these cells here do not have much cytoplasm. So the staining is dark, their staining is dark because hematoxylin stains the nuclei. So what color is the cytoplasm stained? What stain is there for the cytoplasm? Which one? Which stain is it? It's
Eosin.
eosin. And this is pink. So these cells, which are more mature cells, that means they have more cytoplasm because the more primitive is one cell, the bigger the nucleus is. The more mature is the cell, that's the bigger amount the cytoplasms take. So these cells here are more mature cells, and this is a normal squamous covering epithelium. All right? So these cells are more pink because they stain with eosin, which stains their cytoplasms. The other cells are more dark because they stain with hematoxylin, which stains the nuclei. So that was one slide. Let's have a look at another slide. Now, here, we have another tissue. Like here, have a look at this tissue section. And let me find a place that we can see the structure of this tissue. So does this look epithelial tissue? Like the covering epithelium we saw in the skin. Does this look epithelial tissue? Who can tell me? We're just chatting now. I don't examine you. Is that clear? Does everybody understand that we're having a chat now, not an exam? Am I clear to what I say? So you can say anything you like. Be wrong, no problem. That's my job here, to get the things right. Okay? So, do you think this is epithelial tissue or not? Have a look at the shape of the cells. how do they look like? Look, how do these cells look like?
Squashed and elongated.
Spindle shape.
Excellent. Yes, yes, that's right. They are elongated cells. And when we have this cellular morphology, this is not consistent with epithelial tissue. Do you remember which tissues have cells with such elongated morphology? Which tissues do that?
Muscles.
Smooth muscle.
Smooth, excellent. So this is smooth muscle. All these tissues are called mesenchymal tissues. That means they derive from the mesenchyme. So as you excellently recognized, this is smooth muscle, all right? And the smooth muscle in our body, which has a very wide distribution, all the organs with cavities have smooth muscle on their wall. Vessels as well, they have smooth muscles, and these cells form interlacing bundles, all right? So this is smooth muscle tissue. In this particular tissue sections, it's from the wall of the uterus, all right? So that's very good. You recognized smooth muscle, and this is very encouraging. Now, let's have a look at this tissue here. Let's have a look. Now, let's leave pathology and look at normal tissue. Now, how would you describe these structures here? Have a look. These structures. How would you describe these structures? Is this epithelial tissue? Is this epithelial tissue? What
Yes.
do you think? Yes, it is. Excellent. It's not covering epithelium. Where do we meet covering epithelium? We saw the skin. Where else do we meet covering epithelium? In all organs which have a lumen, a cavity. That means the oral cavity. It's the mucosa, all right? All internal organs which have cavities, uterus, urinary bladder, colon, large intestine, small intestine, stomach, esophagus, bronchi, all these organs have mucosa, and this is covering epithelium. This organ is of epithelial origin, it has epithelium, but this is not mucosal epithelium because this organ does not have a cavity. So there's no mucosa here. So this is epithelial tissue. And what type of epithelium is it? Is it like the previous one, which we saw the stratified epithelium? What sort of epithelium is this?
Cuboidal.
Excellent. This is a cuboidal. Here is the tube. You see the cubes? Here are the cubes.
Well,
In general, we say this is glandular epithelium. All right? It forms glands. And how do we understand that? There is a lumen. You see the lumen here? And it has some content, which content is produced by these cells, the glandular cells. So these are glands, and they produce something. Is it mucin? Could that be from the mucosa of the large bowel of the colon? No, because this is not a covering epithelium. It's a solid organ made of epithelial tissue, glandular epithelial tissue, which produces this. Have you any idea what this could be?
The
If I can help you and tell you the content.
The thyroid.
Excellent. So I'm very glad because I can see that you understand histology, and this is the principle to understand histopathology. All right. So I'm quite confident that we are going to cooperate in a very productive way in our lessons. Now, and it's almost, it's past 12. So let's have a look. I have something else to show you. I would just like to show you a covering epithelium, which is of, let's have a look at this one. What is this? All right, we'll see that. Okay. This is a covering epithelium, all right? Have a look. Is it the squamous stratified epithelium that we saw on the skin? No, it isn't. This is what type of epithelium is this that covers this surface? And this is the connective tissue. By the way, what are these in the connective tissue? What are these? Oh, have a look here. This one. Can you identify this structure in the lamina propria or in the
Blood
connective?
vessel.
Yes, please.
Blood vessel.
A blood vessel, yes. And what is the lining of the blood vessel? It's endothelium, all right? So glands have lumen. Vessels have lumen too. Vessels are covered by endothelium. Glands are lined, not covered, lined by epithelium, all right? So this is a glandular epithelium. And could you please identify what is this in the cytoplasm of this simple glandular epithelium? What is this? What generally does glandular epithelium produce?
Mucus.
All right. I think excellent. Yes, it's mucus. It's a mucin-producing epithelium. However, these are not goblet cells, as we see in the colon. Do you have any idea in which part mucus is like this in the glandular cells?
Maybe respiratory tract.
It could be the respiratory, but there we could identify the cilia, those that throw the particle away. So it's not likely that it's in a bronchus. However, that epithelium would be very similar to this one, as you said. Any other part, which is this sort of epithelium, and up to a point, it becomes then squamous. I think that's a bit difficult. Shall I say it?
The cervix.
The cervix, excellent. Yes, very good. Very, very nice. Very nice. So that's all our histology. Our histology review. Okay. Now, let's have a look at the documents, all right, in your portfolio. The education. Since I'm your supervisor, we'll try, I believe, in two things. And everybody who, and if somebody is interested, you can have a look in this literature of mine. So what do I have to, do I want you to take notice? Education means interactivity. That means we're not passively listening to something. We're not passive listeners. We're not pathetic. We communicate with each other. Today, we communicate via the PC. Hopefully in our next meetings, we'll communicate face to face without technology, because this is very important, because it's related to the experiential way of learning. So the second principle that I follow is experiential learning. The concept that first we learn theory and then we come to practice, to my view, is wrong. No, science begins with when we see something, all right? And then we see something, we discuss it, we understand it, we have the experience of something, and then we try and study the theory behind. So in all our lessons, we'll start from practical problems you'll see in the patients, which will come shortly, and you'll have to deal with them. So that's my way, all right? Two things, experiential learning and communication. So, not exams, all right? Leave the exams away. It's not their time yet. So here is all, yes, here are the chapters in the documents, and we can see this is the first category. the introduction. You can see my views on education here in this selection of files. And now it's time that we start our lesson today with what is pathology. We'll have two PowerPoints. I'll pass very quickly on my PowerPoint, and then we'll have a more detailed view of the other one. So what we do, we know how the normal structure of tissues is, as we discussed previously in watching our virtual slides, and we compare the normal structure to the abnormal structures. And we have to deal with all diseases, all the diseases of human body, how they put their imprints on tissues. So you can understand that our field is enormous. All right? So we start from the observation, what is different from the normal, and then we have some models of lesions which we try to put our findings in. The two basic models of diseases that we'll deal with are inflammation and neoplasia. All right? This is a very basic difference, because if we diagnose an inflammatory procedure, what do you think that the primary treatment will be? If we have inflammation.
Anti-inflammatories.
Yes, please.
Anti-inflammatories.
Yes, it will be a medication, all right? It will be a conservative treatment. On the other hand, if we diagnose neoplasia, either benign or malignant cancer, which is the primary therapy for such a disease, in your opinion?
Radiotherapy or excision.
Excellent. That's right. So we have to give the clinician the direction, what he's going to do, because the clinician has the symptoms of the patient, all the laboratory data up till the tissue is taken from him. So we are coming to let him know what this is about, because we look at the tissue. We look at the tissue of the patient. And so we give this information to the clinician, and he treats his patient or her patient accordingly. But you should always take into account that the microscope is not an analyzer where you put the tissue and then a diagnosis comes out. No. The microscope is an organ that we, according to our experience, and we judge the significance of the microscopic and macroscopic gross findings, so that we understand what is going wrong and make the diagnosis. All right? So in order to have a correct pathological diagnosis, it is mandatory, it is indispensable that we get the relevant clinical information from the patient and a summary of all that he knows up till the time he takes the tissue out of the patient. So don't forget, when you become clinicians, do not just throw a piece of tissue in the pathology department. Always cooperate with the pathologist and let him know what you think of the patient and what are the so far findings for the patient. This is of fundamental importance so that the correct pathologic diagnosis is solved. Because everybody says that, all right, we communicate mainly with doctors, not with patients. However, look here. We are doctors who work in a laboratory. However, our work is not only laboratory work. It binds laboratory to clinical medicine. So this is an excellent introduction for you. For the clinical medicine, you are going to be accustomed with from the next semester. So, because pathologists work like a black box, in a black box, which transforms the sample into diagnosis. What does the clinician say? We are waiting for the results. What he really waits is not the results that come from an analyzer and a machine. He waits for the pathologist to make the diagnosis. So we are not solely working in the lab. We mainly work in the lab, but we connect with the clinical findings of the patient. So what is, here are some direct contact we have with the patient. You can have a look on the slides. And we start from anatomy, of course. And the last slide I want to comment on is this one. Yes, this one. So the pathologist, here we are, is an integral member of the healthcare team. Nowadays, medicine is not a one-man show. All doctors should learn to communicate and respect the role of each one and its contribution to the patient's health. So the pathologist is an integral member of the healthcare team, advises on test selection, evaluates results, and can explain outcomes both to his colleagues, to the other doctors, and of course, sometimes to patients directly. All right? So this is some basic information, and now we'll pass to the main presentation, which is this PowerPoint document which was prepared by the director of the department, Professor Nikolaos Kavantzas, and I have studied it and we'll discuss it together. Up till now, is there something that you want to discuss with me before we pass on the main content of our meeting today? Let me see. Is there anything we would like to say? All right. So we'll go on. So, all right, we have already made the distinctions between histology, which is the object of which is the normal structure, and pathology, which studies diseases and deviations from the normal at a cellular and tissue level. Because one part of our specialty is cytopathology, where we have smears of cells. If we talk if we talk about histopathology, we have the structure of the tissue, and we look the structure and the cellular details. If we have a cytological specimen, we just have smears of cells, either from exfoliative cytology, that means cells that fall in cavities or are taken from some mucosa, for example, the Papa-Nicolau test for the cervix, the epithelium of the cervix. And another way of cytology is through fine needle aspiration, where we put a needle and take cells from different parts of a lesion. And most often, this is we have a radiologic guidance. That means where we'll take the cells from. So in these cases, we have cytological smears. In other cases, we have biopsies, taken from various parts of the body, for example, stomach, bowel, urinary bladder. These are biopsies, all right? And furthermore, if a surgery follows, then we have the whole or part of an organ. So we examine it grossly, macroscopically, and then we take sections and examine them in the microscope. So surgical or autopsy preparations, because one part of our specialty has to do with autopsies. Here we have in everyday practice, we have some parts of organs, and we do not perform the autopsy ourselves. However, we should know how an autopsy is performed, is within our specialty. As far as hospital deaths are concerned, not when there is some sort of a criminal action. This is another specialty which takes care of these things. However, we can help forensic medicine by examining parts of organs which are sent to our lab. So, biopsies in the form of small tissue samples, not too small. We always want adequate material so that we have our diagnosis properly based from various parts of the body. And all this helps to make the diagnosis. So you can see all these sites where we have fine needle biopsy specimens. And as I told you before, if we have fine needle biopsy specimens, what sort of slides, of what sort of specimens do we examine through fine needle biopsy? Remember, I told you?
Epithelia cells.
Yes, please.
Epithelia.
Yes, mainly it's epithelial
products.
cells, yes. But what we have on the slide, is it a tissue or something else from fine needle biopsy? We have the
Liquid.
cytological smears, right? We have cells, not tissues with architecture, but collections of cells, which, however, may have some architectural criteria, but the main basis of cytology is cellular morphology, not tissue structure. Tissue structure is the basis of histopathology. Now, endoscopic biopsies, have a look here. All these sites, from all these sites, we can have biopsies. These are small tissue specimens, and our main differential diagnosis is, remember what we said? Inflammation or neoplasia. These are the two basic groups of diseases that we deal with. We can have some transvascular or interventional biopsies from the heart, immediate biopsies from the cervix, and carotids. Carotids is when there is a cavity, for example, the uterus, and you want to evacuate all this tissue there. So you have a carotids, and we have many specimens. The same happens from the prostate. If the prostate is enlarged and compresses the urethra, you have carotid specimens because the urologist goes in the urethra and takes all the carotids from the hyperplastic prostate. Now, here is a palpable abnormality. You can see here a lump in the breast. A very easy way to get cells is the FNA, the fine needle aspiration, which takes cells. And so, first of all, we have the clinical examination. What is the clinical examination? We touch the lesion in case these are lesions which can be touched. Because if it cannot be touched, can you tell me another screening method for lumps on the breast? If it's a lesion that the patient touches,
Mastography.
mastography. Very well. What's your name, my friend? What's your name?
Andreas, same as yours.
Okay, Andreas. Right. How many people are watching? I'm not sure I can see everybody. How many are they? Can you tell me, Andreas?
Around 40, 35.
35. All right. So I want the rest to answer to me. Not all, not one person anytime. As I told you, we're not having exams here. Is that clear? Tell me the
Yes.
remaining. Is that clear that we are not doing an exam now? Is this
Yes.
clear to you?
Yes, yes.
Yes, all right. I am not interested in exams. Wake up, my friend. Do you want some coffee? Let's to order some coffee. So, because I want you to be active. All right? Not in a way of boring. No, that's not my way. It's not my way. I want you to be active. Learning is an active procedure. All right? So that's how you find the tissue which is wrong and take the sample. Okay.
Excuse me, can I ask something?
Of course you can.
So if you take middle aspiration, how do we know from which tissue the neoplasia stems from?
Yes. If you touch it with your hand, and then you see where the needle goes. In case that you cannot, it cannot be touched, you have ultrasonography in the patient, and then you see where the needle goes. And
No, I'm asking, sorry to interrupt you. I'm asking, so how do we know if the, let's say, for example, the adipocytes are the ones which are malignant, or the glands of the mammary tissue?
that has to do with your microscopic evaluation. The adipocytes are totally different in structure than epithelial elements of the breast. So you judge according to the morphology and discriminate the cells. These are epithelial cells. These are adipocytes. The epithelial cells, what are their characteristics? Are they close to normal or are they close to atypia? But this we'll discuss in due course. So non-palpable abnormalities, all right? That means we cannot touch the lesion. Here we have the radiology to help the clinician take the representative material. Now, endoscopic biopsies. You see here the bronchoscope. So it takes tissues from the bronchi, and sometimes it can go through the bronchus and find an adjacent lesion which is radiographically present, and so take the representative tissue. So it is for us to examine. So you see here the bronchoscopy. In a similar way, we can have tissues from gastroscopy, colonoscopy, endoscopy of the urinary bladder, and the uterus. All these sites have a similar way of taking tissue. This is endoscopy. Now, what we do with tissues, all right? We collect, we have the fixation, which is formalin. A solution of formalin is the most widely used. Then the tissues are hydrated, and then they come embedded in wax. They form blocks. And then we cut, the technicians cut sections from paraffin blocks, because that's the wax we use, it's paraffin. And then we stain the sections primarily with hematoxylin and eosin, and we have what we have on the glass slides to observe in the microscope. So the tissue collections, you see all the type of specimens here. The 10% formaldehyde solution, this is formalin. And in case we have biopsies, we count the biopsies. And we see we counted 3 specimens, and we have on the glass slide 3. So it's okay. But in case we have parts or organs, complete organs which have been excised, we have the macroscopy, the gross examination. All right? So here it comes. The material comes to our department, and of course its number. Here is a gross specimen, which you see this color we put on a gross surgical specimen. You see that this is some sort of ink. Of course, we measure the size of the lesion of the whole specimen, its weight, especially if endocrine organs are concerned. What do you think that this, why did we put this black ink and we have it all around the specimen? Can you guess why do we do that?
So
And-
when we cut the specimen,
That's very good.
we can know which
Yes.
one is the external
Yes,
side.
yes, Katerina. We have the ink, and we have it to become dry, so that when we cut the specimen, the ink does not go in the tissue, but it stays on its outer surface. What do you think that this would be of interest if this is a specimen with cancer in it? What do you think? Either you, Katerina, or any other friend can tell me. Yes, please. What does the surgeon want to know? Which information does he want to take from us? And we have this periphery, the periphery of the specimen, of his specimen, inked. What information does he want to know?
To see if when removing the tumor or the
Yes.
neoplasia, if we have clean margins.
Excellent.
If we remove
So
the
as to
entire thing.
fix the margins of dissections, that's our job. If we have a lesion, and this lesion is a neoplasm and a malignant neoplasm, we should tell the clinician how safe the surgeon, how safe his margins are. So that's why
What do you mean by margins, sir?
the outer, here, if cancer is in contact with the ink, what does the surgeon understand? It will relapse. It will grow again. So he has to do something after the surgery, either more thorough excision or radiation, so as to prevent a local relapse of the disease. Yes, here we have the blocks where the paraffin and the tissue is, and of course we should never leave tissues out of formalin, because they will be destroyed through autolysis, and we have a time of fixation for each tissue. And then we try to take thin sections, our technicians, so that we have nice morphology on the microscope. And here we have how the final slide, the final section is put on the slide. This is the block with the paraffin, and here is the tissue, and this is where it's going to be cut. Now, this is the histockinet, where we have a gradual increase in the solutions as far as ethanol is concerned, and the final pot is xylol, all right? And thus the tissue is dehydrated, and so it can be cut. This is the microtome where we cut, And sometimes we have to deal with rapid biopsy. That means the patient is having the surgery now, and the doctor wants to get an information within 10 minutes. Is it cancer? Is it not cancer? Are margins free or not? In this case, we freeze the tissue. We do not fixate it in formalin. We freeze the tissue, and we have the frozen section. We have to put it on the microscope within 10 minutes and tell the surgeon whether it's cancer or not and how safe his margins are. So the margins are not only examined in the surgical specimens, sometimes the margins are examined in biopsies from which frozen sections are taken. So here are the slides, the glass slides. We put the sections, and the staining is hematoxylin and eosin. This is the most widely, the first stain is used. Do all friends know what hematoxylin stains? So can we repeat that, please? What does hematoxylin stain in cells? Who can tell me? Not you, Andreas, of the other, somebody of the other friends who are
The
watching.
nucleus.
That's right. And what color does it stain in, Marcos?
Purple.
Purple. That's right. And eosin, what does eosin stain in tissues?
The cytoplasm.
The cytoplasm. And what color is it?
Pink.
Excellent. Apart from the cytoplasm of cells, eosin also stains collagen. That means not cells, parts of the extracellular matrix, collagen, and some areas of necrosis where we have no tissue, they are stained by eosin. But we'll talk on this on our next lesson on Wednesday, either through the PC or hopefully in direct contact. We'll see. We'll let you know. Here is the hematoxylin, you see, cytoplasm, and the nuclei, the eosin stains the cytoplasm pink, and the hematoxylin stains the nuclei blue. The optical microscope, the electron microscope, which we have great magnification, and look how big the nucleus form, and the cytoplasm with all these vesicles. Histochemical stains. Here are other stains. For example, the Alcyon blue stain and the PAS stain can be used for mucins. PAS stain is also used for basement membranes and areas where collagen is deposited. Congo red detects amyloid. Elastica, Giemsa for Helicobacter pylori bacteria and for mast cells. Gomori, you can tell the difference between collagen and muscle tissue. Gram is something you learned in microbiology, but we sometimes use it on tissue sections. Mason is a very useful stain because it detects collagen as a somehow green to light blue, and muscle tissue, which is stained differently. Iron stains are implemented. Mucicarmine with neutral mucins. Grocot methenamine, this is for fungi. Reticulin, that means the reticulin figures, and foncosa for calcium deposits. Oh, this is PAS. You see the PAS positive cells? When we use PAS, we want to discriminate between glycogen and mucin. So we use PAS with diastase. If the stain persists on diastase treatment, this is mucin, neutral mucin. If staining does not persist after diastase treatment, this is glycogen. Okay, is this clear? What's the use of PAS stain? Used on its own, it stains both glycogen and neutral mucin. When we have past diastase, glycogen is not resistant. It is not stained. Mucin is positive after diastase retreatment. So glycogen is past positive, but past diastase negative. Neutral mucin is past positive and past diastase positive. Okay. Now, Gimsa, you see the Helicobacter? What sort of tissue is this? Can you tell me what sort of tissue this is? Can you tell me, please? You see the lumen here? Who's going to tell you? Who's going to tell me? Where are the rest? Let
A
me see.
blood vessel.
Next page, just a moment. Oh, here are my friends. Another. Angelique, do you know? Do you know, my dear? There's no problem if you don't know. That's why I'm here, to make you know. That's my job, all right? Don't feel embarrassed, no problem. Christina, what
Can
did
you repeat the question, please?
Yes, can you tell me what sort of tissue is this? Is this epithelial tissue? Do you have
Uh,
any idea?
I would think it's glandular epithelium.
Excellent. It's the gastric pits, glandular epithelium, mucus producing. However, with this stain, can you see this here? Can you see this? Which are stained by Gimsa? These are Helicobacter. So this is some sort of gastritis, as we'll soon learn. Yes, next. The mason. You see the connective tissue? You see here? What color is it, Elia? You see the color? So what color does mason stain the connective tissue? What color does it stain? Have a look here.
Blue.
Blue. And here, the muscle tissue, what color is it?
Red.
Red. So you can make the distinction, all right? Elastica. Here are the elastic fibers, stained black. Amyloid is this color you see here, right, coming down from the endothelium of the vessels, and when we have polarized light, you see how the amyloid is shown under polarized light. Now, immunohistochemistry. When we want some markers that are not evident by histochemical stains, we have antibodies and stain cells which bear these markers. So we have a look here. These cells are atypical cells. That means they are 2-pi hyperchromatic. And due to the markers that express cytokeratin, this is an epithelial marker. TTF1 is a marker of lung deviation and thyroid. Napsin is another marker, and this consists that these cells, which we cannot discriminate from morphology, if they are glandular, are they squamous? We have the immunohistochemical stains, and so we can see where they come from, because cells from squamous deviation should be P63 positive and cytokeratin 5-6 positive. In contrast, these atypical cells express immunohistochemical markers of glandular epithelium. So we can see the origin of these atypical cells and so the patient gets the proper treatment. Okay, but we'll talk on this we'll have many lessons, hopefully. Now, molecular pathology. Here we have molecular techniques, and we can look at the cell genome at the messenger RNA level, and we can have all the gene alterations of abnormal cells, and this is directly related to personalized treatment. For example, in all cancer patients, we no longer use cytotoxic therapy as it was 30 years ago. We see the specific genetic alterations of each patient, and we judge the targeted treatment so that the treatment is efficient. We get the best result. And this is information which molecular pathology gives us. And as you can understand, our specialty is closely related to the clinical image of the patient, both for the diagnosis and the treatment. So pathology is a clinical laboratory specialty. So we need to communicate with clinicians. We help them do their job right. From history, we have the founder of modern pathology, Virchow, and when you come to the lab, you can see all the specimens that he had donated to our department. And in Greece, this is the first professor in pathology, Theodoros Afendoulis. This is our department and a brief history. And I'm glad that I managed to finish on time. And is there anything else now we want to discuss? My friends here, Katerina, Maria, Petros. I think we'll get to know each other with our first name. So it's very good because we have a group of students that permits this this belief of mine that is interactivity and communication. So I'm sure we'll manage to do that. Stelios, Panagiotis, Analabos, all right.
Professor,
Yes, please.
about the E-class registration.
Yes.
I've sent a request. I don't know if the rest have already.
Should I make it accept? Should I accept it?
Yes.
I'm not the one. I think. Let me have a look. Let me have a look here. Here is the. Here we are. Now here, 41 registered. That means that includes some of us. You can contact Christos, and in case you have any problem, now that we are always have a look at the announcements, please, and you'll have a look at the documents. As far as our lesson is concerned, here is the basic PowerPoint document, and all these are other documents of mine which you can have a look. The education in pathology literature and some basics of pathology. And everybody, if somebody is interested in philosophy, he can have a look at the whole document. However, this is the main document which we have discussed in thorough during our lesson. As far as our next lesson is concerned, on Wednesday, you'll have a look at the announcements, how it will be done, and if it's done as a live lesson, where we shall meet. You have my email. I think it's here in the description of the lesson. Here we are. This is me. You can come to me every Thursday at my office. And this is the email of Mrs. Yannery, who is the secretary. Here's my email. You can contact me anytime. I'll be very glad to communicate with you, either by email or by direct contact. Okay? See you on Wednesday.
Thank you.
Okay.
Thank you.
Bye-bye.
Thank you.
Bye-bye.